Hi, my name is Dr. Pedro Cortés. I am a third year resident in the internal medicine program at Mayo Clinic in Jacksonville, Florida. On behalf of all the co authors, Dr. Kumbari, Dr. Anwi, Dr. Wallace, Dr. Raimundo, Dr. Yi, and Dr. Yanbi, we would like to thank Gastrointestinal Endoscopy for inviting us to give this interview on our study titled A Simple Risk Score to Predict the Likelihood of a Positive EUS in Idiopathic Acute Pancreatitis, abbreviated as IAP, in this interview. The purpose of our study was to derive a risk score that could be used as a decision tool to determine the diagnostic yield of EUS in patients with IAP. The most recent guidelines published in 2013 recommend obtaining a repeated abdominal ultrasound after the initial inflammation has resolved to determine an etiology. However, only 10 to 20% of patients have a repeat abdominal ultrasound. Additionally, the guidelines of the American College of Gastroenterology and the International Association of Pancreatology differ in their recommendations on the clinical utility of EUS. Whereas the ACG guidelines do not recommend EUS, the IAP guidelines do recommend an EUS as a way to determine an etiology. Currently, there is a need for a risk score in patients with IAP as there is tremendous heterogeneity in its diagnostic evaluation. We carried out a retrospective study including all 3 Mayo sites. We identified patients with IAP who underwent EUS by using ICD-10 codes for acute pancreatitis and procedural codes for EUS. We excluded patients who had an underlying etiology discovered prior to the EUS. A total of 180 patients with presumed IAP were included in our study. A positive EUS was defined as an EUS showing an etiology that has been associated with acute pancreatitis. We found the most common etiologies in IAP were a cold biliary disease and chronic pancreatitis as previously reported in other studies. Structural abnormalities and fatty pancreas were also very common findings in these patients. Our study also showed that obesity and age were the strongest predictors for a positive EUS in patients with IAP. Age greater than or equal to 65 was associated with a higher frequency of a cold biliary disease, and younger age was associated with other etiologies diagnosed on biopsy, such as autoimmune pancreatitis. Similarly, we found that obesity was associated with a higher rate of fatty pancreas and with a non-significant decreased frequency of a cold biliary disease at a p-value equal to 0.054. Other positive predictors discovered included male gender and having a delayed EUS, which we define as one occurring approximately 3 months after the latest episode of acute pancreatitis. The reason for delaying the EUS is to allow for resolution of acute pancreatitis and to improve the visualization of the pancreatic parenchyma. We found that for every 2 weeks that the EUS was delayed, there was a 40% increased odds of having the EUS show resolved pancreatitis. As a negative predictor, we found that having had a repeated transabdominal ultrasound decreased the odds of a positive EUS by 65%. Other variables included in the full model were having had a cholecystectomy, MRCP, and having a single versus recurrent episode of IAP. We derived a risk score using multivariable logistic regression analysis and constructed 2 models of the strongest predictors for a positive EUS. In the simplified model, we took the 5 strongest predictors and assigned weighted points according to the odds ratios. A calibration evaluation showed that as the score increased, so did the observed rate of a positive EUS. The area under the receiver operating curve for the simplified model was 0.78, which indicates a good predictive value of our model. Given the small sample size, however, we were unable to externally validate the risk score. So in summary, we derived a risk score that we named DORM65, which is an easily calculated risk score of 5 variables that are known prior to an EUS. These variables include D for delayed EUS, O for obesity, R for repeated transabdominal ultrasound, M for male gender, and 65 for age greater than or equal to 65. We found that our risk score was very accurate in patients with idiopathic acute pancreatitis in determining a positive EUS. We believe that our risk score will help clinicians in making decisions on utilizing EUS for the evaluation of patients with IAP or idiopathic recurrent acute pancreatitis. Thank you.